Namaskar. I am Dr. Hitesh Shah. I am head of the Department of Cardiology at Rajasthan Hospital, Shahibag, Ahmedabad, and I am owner of Kahan Cardiac Clinic at Shahibag, Ahmedabad. I am an interventional cardiologist. What we are going to discuss is regarding angiotensin receptor blocker usage in COVID-19. To date, the 2019 novel COVID virus outbreak is being the major concern for the scientific community to treat with the potential medications. Following a rapid increase in the cases of COVID, different observational studies are undertaken to identify the possible risk factor for infection and related poor outcomes. 17% of the diabetic cases were reported among 52 critically ill patients with the COVID, and 16.2% of diabetes and 23.7% hypertension cases were identified from the 1,099 patients by Guan et al. Study. Similarly, out of 140 hospitalized patients, 12% of the diabetic and 13% of the hypertension cases were observed in a critically ill patient with COVID-19. That were documented in the various references. Hypertension was independently associated with the severity of the COVID-19 on admission, and hypertension is also a risk factor for aggravation of the disease in a COVID-19 patients. The large percentage of the patient with the hypertension undertaking ACE inhibitors or ARBs was a remarkable characteristics among those presenting with the severe COVID-19 manifestation. These classes of antihypertensive massively used as a first-line therapy due to their additional kidney and cardiological protection that occurs regardless of their uses for blood pressure control. That is so-called pleiotropic effect of this agent. ACE2 is established as a functional receptor for entry of SARS-CoV virus into the cell, and COVID enters into the host epithelial cells after its spike protein receptor binding domain binds to the membrane-bound ACE2 receptor, and ACE2 is a type 1 integral membrane glycoprotein. The highest expression of ACE2 is observed in the kidney, the endothelium, the lung, and in the heart. The probable rationale proposed and possible relation between the use of ACE inhibitor ARB and progression of ARDS in COVID-19 is increased availability of the ACE2 attached to the surface in the lung endothelium and inherent effect of those two classes, leading to the enhanced coupling of the SARS-CoV virus and to the ACE2 receptor and its consequent cell entry. Receptor binding domain of SARS virus, COVID virus is a strong interaction with the ACE2, and any increase in the ACE2 expression may potentially amplify the virus capacity to enter the cells. Distinctly, ARB increases the angiotensin II availability since this class blocks coupling with the AT2 receptor, leading to compensatory upregulation of the ACE2 in the membrane. Cellular entry is followed by endocytosis and further viral replication and subsequent release. And SARS-CoV virus after entry inside the cell causes downregulation of the further ACE2 expression. ACE2 is responsible for conversion into the angiotensin 1 to 7 and inactive angiotensin 1 to 9. That is a downregulation of the ACE2 results in the unopposed action of the angiotensin 2 through its AT1 receptor. And ARB, that is angiotensin receptor blocker, opposes the angiotensin 2 action by blocking its synthesis and the receptor. And ARB may cause overexpression of the soluble form of ACE2, which intercept with the binding of the SARS-CoV virus with the membrane-bound ACE2, thus inhibiting the viral entry into the host cell. The new data, which was published in the JAMA Network Open, show that after adjusting the multiple variables, COVID-19 patients treated with the ACE inhibitors and ARBs had a significantly lower risk of death and severe adverse event, which include the needs for intubation, mechanical ventilation, or admission to the ICU, when compared with those not receiving the RAS inhibitors. Breast corona trial, which was presented in the ESC Congress, showed that hospitalized patients with the COVID-19 who continued on their previously prescribed ACE inhibitors and ARB were not in the increased risk of dying or remaining in the hospital when compared with those who stopped its medication. In Replace COVID trial, which was published, came to the similar conclusion. So abrupt discontinuation of therapy puts them at a risk of complication, rebound, exacerbation of the disease. In patients with the hypertension, discontinuation or switching a drug can lead to rebound hypertension and transient suboptimal control with the new agent, thus predisposing the patient for the intermittent high blood pressure fluctuation and can augment the risk of developing cardiovascular events. Similarly, in heart failure patient, sudden discontinuation of the ACE inhibitors has been shown to result in the deteriorating clinical status with a possible relative increase in the mortality. In post-time myocardial infarction patients with LV dysfunction, RAS blockade provides mortality benefit. Similarly, use of ACE inhibitor ARB reduces the risk of diabetic complication in patients with the diabetes. Until more data becomes available, we feel that continuation of the ACE or ARB may or may not increase the susceptibility to the SARS-CoV-2 infection, but the sudden discontinuation is more likely to result in the decompensation of the previously stable clinical state. Therefore, based on this data, European Society of Cardiology and American College of Cardiology does not recommend discontinuation of the ACE inhibitor or ARB therapy in patients with heart failure, hypertension, and MI who are also suffering from COVID virus infection. Moreover, S2, whose expression is enhanced with ACE inhibitor or ARB therapy, has ability to suppress the inflammation and has been suggested as a potential new therapy for inflammatory lung disease, cancer, diabetes, and hypertension. Given the fact that no current evidence that proves that direct causal relationship between the use of ACE inhibitor, ARB, and COVID-19 infectivity or mortality, and the fact that ACE inhibitor and ARB have many benefits in the cardiovascular disease. Thank you very much.